A 5-year-old boy with a history of atopy was recently started on a systemic prednisone for a flare-up of his eczema. His mother brought him in because his right eye is red and painful. He had similar episodes during last summer's vacation on the beach with his family. The right eye is injected, and staining of the cornea with fluorescein shows the following pattern. So now that we finished with the case, let's talk about the most likely diagnosis in this patient. So the most likely diagnosis in this patient is that he has affected vision. He has affected vision as well as pain in his eyes, and he gave you the following examination, which is indicative of something that we call, something the doctors call in ophthalmology dendritic ulcer or herpes simplex keratitis. So in other words, I'll call this dendritic ulcer. So in the case of dendritic ulcer, basically this means is that you have inflammation in the cornea. Kera or dendritic ulcer refers to inflammation in the cornea to the point that there is a defect, a hole is in the cornea, a deep hole that formed an ulcer. And this ulcer shape gives the form of a dendrite whenever you stain the eye with a special dye known as fluorescent stain, and it gives you this dendritic shape, which is characteristic of dendritic ulcer. And dendritic ulcer is caused by what? It is caused by a viral infection, most commonly herpes simplex virus. Yes, that very same virus. So let's just have a basic review of what is meant by dendritic ulcer. So I have a very messed up drawing of the cornea. The cornea is the outer part structure of your eye. It is the eye that's literally not visible, it's literally present in your eyeball, but it's transparent, so you can't see it, and you shouldn't. It is transparent and avascular, and it receives its nutrition by diffusion. Its purpose is for any light that I see to be able to be refracted, and so that when it goes to the cornea, it will be in the end be transferred to the retina, and we can interpret this light, or we can convert this light into a signal to be sent to the brain so that it can form an image so that we're able to see. So the cornea helps us able to see. And normally it's transparent. However, when you have inflammation of the cornea, for whatever reason, could be infectious, could be non-infectious, the cornea will be inflamed, and this will be known as keratitis. Now, what happens is that this is a layer of the cornea. Let's say this is the cornea right here, and I divide it into layers. The first layer is the epithelium. The second layer is the Bowman's layer. And this is the Bowman's layer that specifically never regenerates in a cornea if damaged. And this is a problem, because if the epithelium is damaged, it's fine. It will heal. It will be painful for the patient, but it will heal. But if we have inflammation and it causes an ulcer to this degree right here in the Bowman's layer, this will never regenerate, and the healing will be done by a scar. If you have a scarring here in the cornea because the Bowman's layer never regenerates, you'll have what is known as ossification of the cornea. And that's not cataract. Cataract is a ossification of the lens. We're referring to keratitis, in which the complications of keratitis is that it can lead to development of an ulcer, perforation, and this can lead to different types of ulcers caused by different types of causative agents. So a dendritic ulcer is a complication of dendritic, or let's say herpes simplex keratitis. Okay, so that's the idea of it. And then it can extend, this ulcer can extend all the way to the stroma accordingly. Okay, the stroma meaning the CT bundles, the connective tissue bundles that make up the cornea that allows it to be transparent. Now that we get an idea about dendritic ulcer, how do I confirm that this patient might have an ulcer? Or let's say, how can we confirm in general this patient has keratitis? And then we'll think of the types, like dendritic. Well, first, the patient will come to you in the clinic complaining of acute painful visual loss, meaning the patient will not be able to see clearly, his visual acuity is affected, typically unilateral, and he has pain in his eyes together. And this occurred suddenly, so he has sudden loss of vision as well as pain in his eyes. Along with that, he'll have red eyes. There will be conjunctival injection, and this is one of the differential diagnoses of an acute red eye. Accompanied with that, the patient will have photophobia. He's gonna like the lights too much. The patient will also have tearing, or in this case, discharge. In general, viral will have watery discharge, or lacrimation they may call it, or epiphoria, the same thing. or in the case of bacteria, they'll have a case of purulent discharge, okay? So they have constant tearing. So these features right here are kind of characteristic for keratitis. To distinguish it from conjunctivitis, the visual acuity will not be affected in a patient, typically. And there'll be other features as well, but this is one key thing to keep in mind. So what are the differential diagnoses of keratitis? Anything that might cause sudden loss of vision along with eye pain. So we will come in a future video where we will compare this with endophthalmitis, orbital cellulitis, episcleritis, scleritis, acute glaucoma, other conditions that might have similar symptoms, okay? Besides that, before we go to investigation in general, we want to compare the types of bacterial keratitis. And in this one, we're going to think about the infectious form. You have keratitis that may lead to an ulcer due to an infection. So let's compare the causative agents in this case. So let's start with protozoa, or in this case, they call it Echinsuamoeba keratitis, a parasite. And this protozoa, you'll see this in a patient history where a patient is typically someone who wears contact lenses. He's a past contact lens user, and he's been exposed with contact lens. He's been exposed to tap water, or he's been in the swimming pool. So we'll have a young male healthy individual wearing contact lenses, going in the swimming pool. Then a week later, he comes with the same symptoms. And the thing is, he might complain with the same symptoms, but the pain here will be very, very severe. He'll have severe eye pain, disproportionate to his other symptoms. When you examine his eye, you'll see that the symptoms doesn't really match up with the severe pain he feels in his eye. And the reason why, in this case, this patient might suffer from severe eye pain is because in the case of protozoal infection or Echinsuamoeba keratitis, there will be keratoneuritis, meaning this parasite likes to affect the nerve supply of the cornea, which is the trigeminal nerve. And this is what is known as keratoneuritis, which can lead to very severe eye pain. And that's characteristic of Echinsuamoeba keratitis. And when you look under examination, when you do full ophthalmic examination, meaning slit lamp, which is a device that allows you to see the eye in general, and when you do all the other tests, you'll notice around his eye there is a ring-like infiltration around the cornea. So there's like this ring infiltration right here around the cornea, and this is another sign of Echinsuamoeba keratitis. Okay? So that's one very special feature we'll see in Echinsuamoeba keratitis or protozoa. Let's look at bacterial. Bacterial typically is the same as we said before. Bacterial, the most causative agent is a pneumococci, not a staph, pneumococci. And typically, one feature that might be specific to bacteria is something called hypobion ulcer. Meaning what? It means that in the case of bacterial keratitis, you might see the patient in eye examination, the same symptoms in this one in general, but he'll have an eye examination something called as a hypobion. So let's say this is the cornea, and we'll say from interiorly, I'm seeing something white here. I'm seeing something white accumulating in the interior chamber around this region. And this region is known as hypobion. What is meant by hypobion? It means there is a collection of sterile pus, not infected, sterile pus consisting of WBC and fibrin and remnants of iris pigments accumulating in the interior chamber. And this is indicative of bacterial keratitis. Is this specific for bacterial keratitis? No. There are other causes of hypobion, a sign of it. It could be seen in fungal as well. Hypobion also in fungal keratitis. And when we look at future videos, there will be a hypobion seen also in endophthalmitis and uveitis. Okay, but this can help you in removing other types. Besides that, the treatment will come to it shortly. So this is for the bacterial keratitis. Besides bacterial keratitis, we'll look at viral keratitis, which is the diagnosis for this one, dendritic ulcer. And the causative agent for viral keratitis, as we said, is herpes simplex virus, commonly, or it could be its brethren, varicella zoster virus or herpes zoster virus, the same, but typically it's herpes simplex virus that's the case, and this virus is very cruel because this virus right here, it causes this herpetic shape, meaning that whenever you have a patient you suspect is keratitis, you put him under a slit lamp. slit lamp like a microscope. And you basically, before you do the slit lamp exam, you'll do a stain. You'll have a specific stain known as fluorescent stain. Fluorescent stain, basically you apply a fluorescent stain in the eye, and then you'll check under microscope and you'll see a greenish color. That greenish color you saw in the case scenario, that was an example of a fluorescent stain showing you this greenish stuff. And this greenish stuff is indicative that there is definitely a corneal defect. There is definitely an ulcer here, and this ulcer defect took in the shape of a dendrite. So this is a very special feature seen in viral conjunctivitis, or not viral conjunctivitis, in viral keratitis. Sorry, okay? Another feature you might see, and this is something we need to keep in mind as well, is something known as amoeboid ulcer. What is meant by amoeboid ulcer? It means, and this is seen as a rule, if you have a patient with any type of keratitis, do not ever give him topical corticosteroid. Never give him topical steroids, because if you do, you weaken the immunity within the eye. And if you weaken immunity, especially in an infectious condition, this will exacerbate the symptoms and the case even more. So you might see, in case of viral, if you apply a topical steroid, the dendritic shape might become even bigger and take the shape of an amoeba, an actual amoeba. And this is very, very bad. So please take this as a rule. Topical corticosteroids are contraindicated, not just in viral keratitis, in any type of keratitis, okay? So we finished with the viral, and then you go to the fungal. The fungal comes from fungus like Fusarium fungi or Candida. And the one thing we need to do is that if we're making the assumption that this patient might have fungal keratitis, I'll do examination and I'll ask the patient during history, did he have any history of trauma to vegetative objects? Meaning, was his eye exposed to trauma from a tree or from a dust or any organic matter? Because these are places where a fungi might live in. So if he had eye trauma related to these organic matter or trees or dust or any green plant, then this will give you an idea he might have fungal keratitis. He'll have the same symptoms as this one in general, and he'll have a hypobion, which we mentioned before, and you might think, okay, this patient might have fungal keratitis. So don't know what, in general, what are the treatment we'll do for each one? Well, in the case of parasite or protozoa, we can give him neomycin. We can give him neomycin in general as an anti-protozoal. In the case of bacteria, antibiotics, we'll start with topical antibiotics, either topical 45 penicillin or subconjunctival injection of these antibiotics if it's very severe. In the case of viral, we'll give acyclovir, which is an anti-herpetic drug. It will work very, very well. And in the case of fungal, we'll not give neomycin in this case. We can give a case of any antifungal agent, like for example, the conazoles of the world, okay? So we can give the conazoles of the world, ketoconazole, or any other antifungal agent like nystatin that might help us in fungal keratitis, topical. Is this the only thing that's typically done for keratitis? No. Typically, we might give atropine and we might do dressing for the eye, and then we'll wait for the patient. Especially in viral, we have to take very serious cases in viral, where a patient has to take acyclovir, all of these as topical, especially acyclovir, has to take it 5 times a day for 2 weeks at least. As an example, okay? So these are the general differences between other types of keratitis. And we talked about the treatment in general for each one. So what about investigation? Investigation is history from the patient, as well as eye examination. I'll do full ophthalmic examination. I'll check every part of the eye, especially I will apply the fluorescein stain. It will diagnose for me keratitis, that there's definitely ulcer. It might take herpetic shape or dendritic shape, or it could take a shape in general, maybe a circular shape or a non-specific sign. It might go with any of the other types, okay? So I have to do fluorescein stain and then check under microscope. And in the case of bacterial or fungal keratitis, I need to do scrapping from the cornea. I need to take bits and pieces of the cornea here so I can put it on culture and determine which type of bacteria or which type of fungi it might be so I can optimize my treatment, okay? So I need to do that as well. But what about in case of viral or protozoal? No, you'll not do corneal scrapping. Corneal scrapping is reserved for bacterial and fungi, okay? So this is regarding keratitis. And remember, we're talking about infectious keratitis here. This is, for this case, this is dendritic ulcer. But we're talking about infectious keratitis. Can keratitis be caused by a non-infectious cause? Yes. There are other causes. For example, keratomalacia. Keratomalacia means melting of the cornea, and this can be caused by vitamin A deficiency. And also they'll have decreased corneal sensation, where you might have to give this patient, if diagnosed early, vitamin A. Another non-infectious cause is trauma. If you have a trauma not related to green plants or anything, you might have a case of keratitis due to trauma. Okay? You might also have a case of keratitis if, for example, the patient has facial nerve palsy. And if he has facial nerve palsy, he can't close his eye due to the orbicularis oculi muscle. So if he can't close his eye, the eyeball will be exposed to the environment, and they call this ulcer with lac ophthalmos, inability to close your eyelid. And this can cause an ulcer in the cornea, especially the lower 1/3 of the cornea, and this can cause some of the same symptoms. Okay, so you need to take history as well. Does he have any medical diseases like facial nerve palsy? Okay, and you can also have a case of neurotrophic keratitis, in which you have keratitis due to effect of the nerve supply specifically. Let's say you have trigeminal nerve palsy, which is the nerve supply of the cornea, meaning no corneal sensation. If you can't feel the cornea, you'll not have the signs of itching or rubbing or a sign that there's something bothering your eyeball. So decreased corneal sensation due to trigeminal nerve palsy, or let's say, since I forgot to mention it, in the case of viral keratitis, whenever you have decreased corneal sensation, you'll feel no pain. This can lead to the development of an ulcer. And that's the thing I forgot to mention in mind, is that in viral keratitis, one big complication you need to keep in mind is that this virus with recurrency can affect the corneal sensation. You're not able to feel your cornea, especially the corneal reflex, so you'll have corneal hyposthesia or decreased corneal sensation, and this further complicates things because if you're not able to feel what's going on in your eye, you'll not feel no pain, leads to rapid development of the ulcer. Okay, so that's something also to keep in mind, is the corneal sensation as well is going down. That's pretty much it. I talked about non-infectious keratitis and infectious keratitis which you can have in general, and that's pretty much it. Thank you.